Um, all right, it's my pleasure to introduce Will Summers. He's a PGY2 resident who is from Birmingham, Alabama. He went to the University of Alabama for undergrad, where he majored in chemical engineering. He then went on to attend the University of Alabama at Birmingham for medical school, and we are happy to have him here as a resident now. Take it away, Will. We're excited to hear about the nutrition's impact on inflammation and recovery.
Thank you, Malia. So super excited to be giving this talk tonight for a few reasons. The first reason being is that I just love talking about food. I think I've driven every nurse at the university crazy talking about food in the month that I've been there. The second reason being that since I moved here, I've noticed a trend in the patients here that it's very different from where I'm from in the South, is that people here take a much more holistic approach to their care. They're not asking, well, what medicine can I take? They're asking, well, what can I do to prevent or to treat my pain or injury? And so I wanted to look into some of these things because I've gotten a lot of questions throughout this year and last year being here about various diets and supplements. So let's get it going. Good boy. So we've all seen this map before, especially in the South. This has just been ingrained into us that we're last in most everything. So I took the title off this slide or off this graph that I got from the CDC because basically it could represent anything: obesity, heart disease, even education. But this particular image represents the prevalence of chronic pain and joint disease in the United States. And this is from 2018. And so the question I have in my mind is, what if it's not as simple as, well, these people are unhealthy, therefore they have more pain? What if there's more to it than that? What if it has more to do with what we're eating? So based on that, tonight we're going to talk about the principles of an anti-inflammatory diet. I think that there are really two basic principles that apply to most of the diets that come up a lot in the clinical setting. At the same time, we're going to talk about some of the literature and trials where some of these principles are used and how this ties into our microbiome. Then we'll transition into more of our sports recovery. And throughout this whole presentation, we'll be talking about supplements and some of the more commonly used supplements and their role. And I have nothing to disclose. So the first topic of an anti-inflammatory diet comes from the fats that we eat. And again, we've all seen this picture before. We all know this classic pathway of inflammation leading to pain and fever and inflammation. And we know where NSAIDs work, we know where aspirin works, and we know where steroids work, but we never really spend a lot of time talking about arachidonic acid, which is a phospholipid and comes from the diet, or it comes from our diet and the essential fatty acids that we eat, which are the omega-6 fatty acids. But there's also another type of dietary fat that we get, and that's omega-3s. And this is just to show that there's very subtle differences between the two types of fat. The main type of omega-3s are this EPA and DHA seen there on the screen. There's also a third that you can see on the top there, is alpha linoleic acid, and that actually is synthesized into DHA. And both of these, all of these omega-3s, as well as the omega-6s, which are the linoleic acids, are incorporated into our phospholipids in a dose-dependent response, depending on our diet. So what we've found is that these omega-6 fatty acids come from a lot of the animal fats and vegetable fats that we consume, as well as some dairy products. And again, these are synthesized into arachidonic acid. And what you get is that classic pathway of increased pain, fever, inflammation, pain sensitivity as well. But on the other hand, these omega-3s come from fatty fish and other vegetable oils. And what they synthesize to is this, again, EPA, and we get a completely different response. And we get a relaxation of muscles, a decrease in pain, and an improvement in circulation. So the big takeaway that I want everyone to remember is that it's not necessarily about providing an aspirin or treating with an NSAID. It's more about a balance. And so the typical, what it's recommended I've seen in the literature is a ratio of these fats. And so the recommendation is anywhere between a 1-to-1 ratio up to a 4-to-1 ratio of, again, more omega-6s still. But what's commonly seen in the American diet is more closely related to an 8-to-1 and even up to a 40-to-1. So if you think back to that first slide of that map, the lighter blue is still 8-to-1, which is double the recommendation. And whereas in the South, we're talking about up to 20 to 40-to-1 in this omega-6 to omega-3 ratio. So how did we get here? Well, when man started roaming the earth, this is when we developed kind of our evolutionary nutritional needs. We were eating lean meats, fish, fresh fruits and vegetables. And you started seeing this increased trend in fat consumption around the agricultural revolution, which is 10,000 years ago. And what we saw there is this development of mass production over time of more of our grains, our corn, our wheat, and our rice. And these are much more rich in these saturated fatty acids. The other big development that led to this even larger discrepancy here happened around the turn from the 1800s to the 1900s. And this is when the technology was developed to extract the oil from our fat. So again, you see this giant discrepancy in omega-6 to omega-3s, as well as this increase in trans fats. So what happens if we just supplement people with fish oil? Well, there's a couple of meta-analysis studies that I was able to find. And the first one on your left here is looking at inflammatory joint pain, more specifically rheumatoid arthritis and inflammatory bowel disease related arthritis. And this is a meta-analysis looking at 17 randomized controlled trials. What they found is just supplementing, not even changing anything else about someone else's diet, is that supplementing led for 3 to 4 months led to a decrease in patient pain, stiffness, morning stiffness, the number of joints affected, as well as NSAID consumption. And on the right here, this is kind of more of a broad-based chronic pain. So it included things like osteoarthritis, dysmenorrhea, myofascial pain syndrome, and again, rheumatoid arthritis. And so what they found was that they found similar results, but more so and more of an effect in rheumatoid arthritis, as well as dysmenorrhea, interestingly. And so there's so much heterogeneity in these studies, so they're just different doses used in all of these studies that there is no official recommendation that could be used. So we've summed up kind of the use of fatty acids and its role in anti-inflammation. So let's move on to the second one, which is oxidative stress. So the way that I like to think about oxidative stress is, again, a balance of scales. So free radicals versus this antioxidant defense system. And free radicals are produced by regular, normal cellular respiration in the electron transport chain in our mitochondria. But these are very unstable molecules. We need a system to balance these out. But again, this serves as a protective role that leads to this oxidative damage and apoptosis, tissue injury. But it's also been linked to in some chronic diseases such as cancer, depression, is having this imbalance. And so what antioxidants do is that they're able to donate this electron and completely stabilize. But what we see when the balance is off is that you get this immune response, and these immune cells consuming all of this oxygen, leading to even more of an accumulation of reactive oxygen species or free radicals, leading almost to this inflammatory response that is bigger than or out of proportion to what we actually need. So here's an example of how glucose can do this. And this took me forever. I talked to so many dietitians, and no one could give me a response on how like simplified carbohydrates could lead to oxidative stress or inflammation. And I'm not going to spend too much time on this study, or on this slide, but as you can see is that you get these activated glycation end products. And what that is that increases your reactive oxygen species or free radicals, but also glucose itself leads to this nuclear factor activation and DNA damage, as well as a pro-inflammatory response leading to nerve injuries. And this has been associated with complex regional pain syndrome, as well as some painful peripheral neuropathies like diabetic neuropathy and alcoholic neuropathy. This mechanism overall, again, is related to several chronic diseases, including CKD, cancer, COPD, and overall cardiovascular health. So I was able to find this really cool study where this group basically measured the antioxidant content of all of these different and various nutritional supplements and food groups throughout the world. And I just kind of noted some interesting ones, to me at least, that dark chocolate is one of them, as well as, everyone likes to think about red wine, but espresso and coffee is even higher, which is good for us. And then in terms of fruit, we found this, I included this picture of dog rose because it was such a high oxidative content. So for example, like red wine had 3 millimoles per 100 grams, and this dog rose, which grows in Europe and North Africa and Western Asia, has 75. But which I found even cooler was that this bottom picture on the right here of this tree is a tree in Peru. And what this resin here is called dragon's blood, appropriately named, and it has 3,000. So the antioxidant content is 1,000 times greater than red wine. So what have we found when we just supplement people with antioxidants? Well, pointing you over here to this bottom left is this polyphenols study. Polyphenols is an antioxidant that's found in coffee and berries and olive oil. And what this study showed is you can measure the oxidative stress through some urinary studies that are byproducts of oxidative stress. And what they found is that overall, people who had a baseline oxidative stress level that was too high, again, balancing the scales, led to a reduction in oxidative stress, but really had no effect on those that were already in balance. And even if you balance the scales the opposite way, some detrimental things can happen. There's been some pretty large studies looking at beta carotene and vitamin C, which are both antioxidants, showing an increased incidence of lung cancer, as well as vitamin E, which has been linked to an increase in hemorrhagic strokes because it has an effect on anticoagulants, as well as prostate cancer. So I wanted to point out this randomized control trial using blueberry. So this randomized control trial had 63 participants and just basically told these participants not to take any NSAIDs, and they all had knee OA. And they assessed labs, gaits at baseline 2 and 4 months. And so they ground up this blueberry powder or extract and gave it to half, and then the other half got placebo. And what we found is an improvement in pain scores, as well as stiffness and difficulty to perform ADLs using a WOMAC pain score, which is commonly used. And this was not observed in the placebo group. They did not see a change in inflammatory markers. However, some studies looking at other fruits such as pomegranate juice and strawberries have shown an anti-inflammatory conduct result as well. The next trial here is vitamin C, and this is kind of well quoted in that vitamin C, looking at CRPS after wrist fractures. And what they found was that supplementing folks with vitamin C of 500 milligrams led to a relative risk reduction of 0.5 of CRPS. And this was given to people on the day of their injury. So they come into the ER, they start giving them vitamin C and treated for 50 days, and saw that relative risk reduction by 0.5. Interestingly, vitamin C has also been shown to help heal fractures in mice as well. So I wanted to include this WOMAC score or index because it's commonly used, and I'm going to be talking about the results of it a lot. And so you can see that it talks, or it addresses multiple things, including pain, stiffness, and really functional parameters. So it's pretty useful. My wife was recently doing physical therapy, and she said that they did this every time she came in. So we're going to move on to diet. So we kind of summed up the importance or the principles of the anti-inflammatory diet being oxidative stress, the role of antioxidants, as well as the fatty acid utilization. So I wanted to talk more about the diets at this point. So I'm going to be walking through some studies that are inherently limited due to a few things, because it's hard to control have a control group versus a treatment group and have very limited bias, because how could you possibly blind someone that is intermittent fasting or having a low carb diet versus a regular diet? So I understand that there are inherent limitations, but I think that some of these results are interesting regardless. So let's start with the anti-inflammatory diet. So again, if you look at the kind of recommendations here on the left, you can see that basically we're eliminating these red meats that have this high omega-6 to omega-3 ratio, as well as encouraging olive oil, which is high in antioxidants, as well as omega-3s. So a couple of studies, systematic reviews here is OA in the Mediterranean diet. And what they found was that an adherence to this diet was associated with better quality of life, less depression, pain, disability, but again, impossible to blind. And they didn't report any outcome of weight loss, which is known to improve knee osteoarthritis. And then looking at the study on RA, it's found similar conclusions, except in terms of treatment, but not prevention. So let's go on to the vegan diet. The vegan diet is like the anti-inflammatory diet on steroids. So you're completely eliminating animal-based products that have that high 6:3 ratio, as well as those products also have no antioxidant benefit at all. So you're kind of really getting after it. And so this study looking at migraines, so this is pretty interesting that they did a crossover study looking at 16 weeks of a vegan diet, as well as 16 weeks of just no diet changes at all with a 4-week washout in between. They found an improvement in pain scores. I found through reading that people with fibromyalgia, the vast majority of them relate some sort of diet, some sort of nutritional intake as a flare to their symptoms. So the vegan diet, they looked at this control to continue a regular diet versus a vegan diet at 3 months. And again, seeing significant reduction in pain, tender point. So sorry, VAS stands for the visual analog, which is that scale 1 to 10. Significant reductions in tender point stiffness, as well as interesting quality of sleep. So intermittent fasting is a little different. I read that if you completely eliminate any sort of nutritional intake, you have a more advanced protein loss versus just 500 calories a day. And that's not saying that that's easy at all, but it's more you burn your glycogen stores than fat, then protein. But the other interesting thing about the intermittent fasting diet is that it has more of this neuroendocrine function and a much bigger role on mood than the studies that I've mentioned before. So you get this, and this early fasting is 7 to 10 days out, and this is after 7 days out. So what you see is this: you get this enhanced serotonin effect, as well as noradrenaline and epinephrine. So it's almost like this, or noradrenaline and adrenaline. So you almost get this like SNRI effect, which is really cool. Whereas leptin, and I'm going to talk about leptin and adiponectin next, is that these are adipokines, and these are, and what we've learned about adipokines is pretty interesting. So leptin was discovered in 1994 and was kind of revolutionary in terms of what we've learned about adipose tissue, is that it's very much involved as an endocrine gland. And since 1994, when leptin was discovered, there's been over 600 adipokines. So adipose cytokines is what that is. And over time, what we've found is that as people gain adipose tissue, you get this more pro-inflammatory response from your adipose tissue. And the reverse is true. So the more you lose, the more anti-inflammatory adipokines are secreted from your adipose tissue. The way that we could tie this into, for instance, back pain is there's also an inherent, so there's a difference in the role that subcutaneous fat plays versus visceral fat. So the fat you squeeze versus the fat that surrounds your organs. And what we've found is that this has a direct role in the type of bone marrow that we have. And so what we found is that an increase in visceral adipose tissue has led from this more hematopoietic bone marrow, rich in our blood supply and healthy cells, to this more yellow fatty bone marrow. And so what's been proposed is that this could have an or a pro-inflammatory effect and play a role in and inflammation in chronic low back pain, as well as degenerative disc disease. And maybe it's, again, not just as simple as, well, more stress on the back, more pain or more load. And so it's most likely more complicated than that. So moving on, we'll talk about the low carb diet. And so again, I mentioned these advanced glycation end products that are leading to more oxidative stress and this pro-inflammatory response. But it's also been suggested that the microbiome plays a pretty large role in this as well, because when our microbiome are exposed to these simple carbohydrates, we get an increased production of lipopolysaccharides. And what lipopolysaccharides do is they can easily cross the gut-blood barrier and interact with toll-like receptors on macrophages and lead to this overall kind of inflammatory response, or almost like silent inflammatory response. And so this study over here on the right is actually from my med school that I kind of just stumbled upon. And it was looking at low carb diet versus low fat diet in individuals with NEOA. And it's, again, a really small study. But I really like this study because they have a control group here that they just educated on portion control. And so that was their kind of way of controlling for weight loss. And what they found is that they all three of these groups, they fed, it was a 3-week study, they fed the low carb group 20 grams of carbs a day. And they fed the low fat group restricted fat, obviously. And so all three of these groups had insignificant changes between the groups in weight loss. So they all lost weight, but only this low carb group had significant improvements in overall pain, quality of life, and pain intensity. Interesting is that this group of Straith and these group of individuals from UAB has also done a lot of interesting studies in mice showing that diets high in carbohydrates and fat increase microglial activation and spinal cord. It increases peripheral inflammation and prolongs hypersensitivity after an injury. So they compared diet high in carbs, and they just basically had the same injury in all these mice, and the mice that were fed lower carb diets recovered faster, as well as had lower pain sensitivity. So like I mentioned, this treatment group in that last study was fed less than 20 grams of carbs a day, which is really more consistent instead of a low carb diet, more of a keto diet. And the keto diet is interesting because it has more effects, from what I've read, on the central nervous system, and more of a centralized effect. It's well established that the keto diet is beneficial for those with epilepsy due to its controlling kind of neuroinflammation. And so a lot of these same principles apply here, is that you get these, depending on how you want to treat treat the fats that you're intaking on the keto diet, you get these enriched omega-3s, as well as this production of ketone bodies, or this beta hydroxybutyrate. And what is proposed is that this is a strong antioxidant and leads to a decrease in free radicals and an overall anti-inflammatory response. Another interesting role proposed is that adenosine, which has been implicated as neuroprotective in some spinal cord, brain injury, neurodegenerative diseases, has also been shown to increase, leading to an anti-inflammatory response. And lastly, about the keto diet is, again, this role of the microbiome. And what's been shown is that when we have this decrease in lipopolysaccharides that our microbiome produce from simple carbohydrates, it leads to a decrease in neuroexcitability and inflammation. And this is kind of a newer trend in the keto diet, and newer studies have been shown that could be also why it's so helpful for epilepsy. Some precautions when you're thinking about the keto diet, though, is that you get this profound diuresis. And I actually tried this diet a few years ago, and it was miserable. I had the most crazy headache. So one of the main complaints of this is that you get very hypovolemic, and you get very headaches and excessive thirst. And so this would not be somebody that you would want to advise going into surgery, or as well as some electrolyte abnormalities with an increase in AFib as well. So that's something to be mindful of. It can also lead to refractory hyperlipidemia. So now that I've mentioned the microbiome a couple more times, we'll focus on that for a second. So the idea of replacing unhealthy microbiota but with healthier microorganisms has been proposed for over 100 years. The thing about this is that there's such a wide variety in the the bacteria that's offered either through drinks or supplements, that it's been compared to the genetic difference between a human and a lemur. And so there's just no way to make generalized recommendations based off of this. But there is an interesting study that showed, this is by a gentleman, Boer, B-O-E-R, and he showed in 1,400 people with NEOA again, that obesity was directly correlated with this increased production or increased presence of strep species. And what these do again is they make these metabolites in these vesicles that can easily cross through this bloodstream. And what has been proposed is they activate these toll-like receptors, leading to this macrophage activation similar to the pathogenesis of molecular mimicry, which has been proven to cause rheumatoid or rheumatic fever, as well as post-strep reactive arthritis and glomerular nephritis. And so what this study found was that this obesity and this strep species was directly correlated with WOMAC pain scores, as well as joint effusions, and these results have been replicated. Here's a study. This study is out of China, where this was one of the few randomized controlled trials I could find looking at knee arthritis, giving probiotic supplementation. And what they did was they had about 450 participants, and they measured WOMAC scores, visual analog scores over here, as well as inflammatory markers, including CRP. And so they gave half of this group, the treatment group, they gave milk containing this lactobacillus species versus placebo for 6 months. And what they found was a significant reduction in visual, these analog pain scores in the treatment group only, as well as significant reductions in the WOMAC in all categories, as well as a decrease in CRP. So like I said, these are 450 individuals in China. There's no way to generalize this study, but still interesting. Okay, so now that we've talked about the microbiome briefly, let's talk about sports recovery and nutrition. So in general, this is a very individualized science. It depends on multiple things. It's hard to just generalize, but it depends on what activity or sport these individuals are trying to train for, genetics, age, sex, all of these things. But in general, there's no need for supplementation of any sort or any special diet as long as your basic nutritional requirements are being met. The key is repleting carbs before, even during and after, as well as hydration. So not only do you want to maintain your energy sources, but carbs have also been shown to lead to this centralized process and stimulate the CNS that could lead to a better fatigue or less perception of fatigue. But I do want to talk about creatine. Creatine is really interesting, is that 95% of this of creatine is in skeletal muscle. The active, or what we consider the active role of creatine, is to kind of buffer our ATP, that when ATP is hydrolyzed to ADP plus phosphate, we donate phosphocreatine, donates a phosphate back to ADP, which buffers the system a little bit. So as we know, this is how we measure creatinine as well, which is the breakdown of creatine that is not phosphorylated. And we excrete 1 to 3 grams a day. and this is replenished through our diet, as well as our kidney and liver both synthesize these through amino acids. And so what this is, these values here are based on a 70 kilogram individual. And so what we found is a normal diet still isn't quite meeting the full capacity of the creatine stores. So we get creatine from red meat and seafood. And so we need anywhere in between 3 to 5 grams a day. And so a pound of ground beef, for instance, has 1 to 2 grams. So as you can imagine, if we're not meeting our protein requirements, it'd be pretty easy to fall short of this requirement. And vegetarians in particular are at an increased risk. But what we found is if we can supplement and fill these stores, that there are some really interesting effects. And these stores can increase even further when taken with carbohydrates. So to briefly discuss creatine in sports, it's one of the most commonly used supplements among college athletes. There was a study in 2014 looking and showed that up to 30% of baseball players, ice hockey players, lacrosse players were all taking creatine. And it's not a banned substance, but some rules, NCAA rules, prohibit just handing this out. But it's not a banned substance. And so what we've seen in some of these sports studies is that with supplementation, you do in fact get this result in increased phosphocreatine, or this buffering capacity, as well as mass, increased muscle mass, and improve oxidative metabolism. And I'm not gonna walk through all of these studies, but I do want to highlight a few things here. So we've seen that with supplementation, you get a decrease in inflammatory markers like TNF alpha, creatine kinase, and some and prostaglandins that cause inflammation. And some studies have shown that this greater glycogen restoration. So this is important for promoting recovery as well. I really like this study as well, where they supplemented college football players for quite some time and showed that and this was another randomized controlled trial, that the people that were supplemented with creatine had less missed practices and total injuries. And this is replicated again in soccer players and basketball players. It has a profound nature to retain water. So there's some theory that it could improve thermoregulation and heat loss and prevent heat stroke. I mentioned that 95% of creatine was in skeletal muscle, and the other 5% is in your brain. So this is kind of more preliminary studies have shown that it can be act as a neuroprotective agent. So think about like concussions, for instance. All right, so to round out the talk tonight, we're going to talk about some supplements. And I wish so the FDA, just to briefly discuss their role in supplementation in the United States, is their role basically begins after market. So once a supplement is on the market, this is when they're monitoring, and they're monitoring not really efficacy, they're monitoring for adverse effects. And I guess there's some agreement there that the supplements aren't allowed to say directly that they cure or alleviate disease, directly at least. So I spent a lot of time Googling different supplements, and also just noticed that when you go to pharmacies, that turmeric is on every aisle as under like the joint pain or anti-inflammatory. And turmeric actually has been used for centuries, dating back to Indian texts as an anti-inflammatory, wound healer, as well as treatment for certain GI issues. And what we've found throughout time is that it's a very strong antioxidant, so 10 times stronger than vitamin C or E. It also has a role as an inhibitor of COX-2. So here is that. So curcumin is the active ingredient. And so this is a meta-analysis looking at, again, joint arthritis. So this is more knee arthritis, I believe. And so going kind of through these tables real quick is that curcumin versus placebo in A and B has been proven to improve pain scores as well as those WOMAC kind of more functional scores versus placebo. This last one shouldn't say really, I mean, pain medicine, but this is really more comparing it to NSAIDs. And as you can see, there's a similar effect when comparing supplementation with NSAIDs. Some of the considerations for turmeric, though, is that there are some reported side effects such as GI symptoms, hair loss, tachycardia, but this is more if you're eating 1,200 milligrams per day. So sticking under that dose of 1,200 milligrams, it seems to be have a better safety profile. And again, this last one is comparing ibuprofen and diclofenac. The next supplement I want to talk about is glucosamine. So glucosamine is an amino sugar precursor. And its role really is to, at least in theory, promote the synthesis of hyaluronic acid, as well as degrade these enzymes that degrade our cartilage. And what we've found is that the bioavailability is pretty terrible. And this is commonly given with chondroitin, which is more of the structural support in our joints and provides protection against those compressive forces. And so animal studies have been pretty encouraging to this. So I imagine that had a role to do with it getting to market. But what we've found, and this is a systematic review and meta-analysis from Mexico that showed that there is an improved effect when giving glucosamine and chondroitin separately, but not in combination. But it had no effect on WOMAC scores in all categories, including pain, stiffness, and function. And literally, generally, these studies are lacking in any sort of objective finding. So really not the best evidence for these two supplements, at least for knee arthritis. And the last supplement I want to talk about is magnesium. Magnesium is the second highest intracellular cation behind calcium. And 2/3 of it are in our bones, with 30% intracellular. So, and then less than 2% is in our bloodstream. And even of that less than 2%, some of that is bound to proteins. So when we talk about measuring plasma magnesium, this isn't really a reliable measure of our whole body stores. And in fact, the more we learn about magnesium, we've learned that more of the general population is at risk for hypomagnesemia. And certain medications can cause that, including PPIs and certain diuretics, but also alcohol use. And we're learning more about these genetic inheritances that can cause it as well. So our daily requirements of magnesium are 400 milligrams. And just these are some of the foods with higher magnesium levels. So one medium avocado is 58 milligrams. And again, we need 400. And 1 cup of black beans, so a whole cup of black beans is 120. So again, you can imagine how certain people with limited diets might not be getting their total body needs. So the reason why this magnesium came up over and over again was for the treatment of migraines. And it has a role as an IV agent. There are some studies, a recent study showed, that's not mentioned in this slide, was from January of this year, showing 150 emergency visits, people who came in with migraines were treated in a randomized controlled trial with magnesium versus Reglan versus prochlorperazine. And these all showed similar analgesic effects in the treatment of migraine. And these are all IV. But here are some, these two studies, I don't know, maybe it was late at night and it made me laugh, but these studies really made me laugh because these are in the same journal article and back to back. So that was, I don't know why I thought that was funny, but it was. Anyway, because they're completely contradicting conclusions. But low magnesium has been associated with cortical spread depression, which explains the phenomena of an aura, as well as been associated with platelet aggregation, release of substance P, vasoconstriction, and NMDA receptors. So after we had our pain lectures last month, I tried to figure out if there were any foods that interacted with these NMDA receptors, but I was able to find an interesting role for magnesium, in that magnesium is almost like a gate holder for active or activation of the NMDA receptor. So at its resting state, this is closed with magnesium bound here. And once glutamate and glycine come to activate it, you're still not getting that that activation of the receptor, the opening of the receptor, until magnesium is released from the channel. And these are voltage gated magnesium channels. So you imagine if you have a ton of magnesium inside the cell and not allowed out here, or relatively not out here, that this would be even easier to overcome and cause this opening. So I was able to find an interesting study here that I really like this study design. This is from Egypt, but it's a double-blinded randomized controlled trial. And they basically found 80 people, and they all took this assessment here. It's this Leeds assessment and pain scale. And I'll talk about that in a second. But they found that this correlated with a neuropathic pain, or neuropathic component of chronic low back pain. And they stopped everyone's medications and all put them on a regimen of amitriptyline and gabapentin. And they treated the treatment group with IV magnesium for 2 weeks, and the other group, the control group, got normal saline. And then the treatment group got 500 milligrams of magnesium BID. So again, they got IV magnesium and then BID magnesium. And they measured, in the control group got placebo. And so what they did was they measured pain, as well as had the same physiotherapist measure range of motion. And what you can see here is after 2 weeks, similar pain scores in the control and magnesium groups. But these in the treatment group were only persistent in the magnesium groups, as well as this, as well as the effects on range of motion. So only the treatment group had this increased range of motion in all directions with magnesium supplementation. So here again is this Leeds assessment of neuropathic pain. I'm honestly not sure how commonly this is used, but a lot of these questions, if you read it, are correlated with similar, at least into the Bethesda criteria. And I just thought that was interesting, so I looked into that as well. And I was able to find a couple of small randomized control trials that showed people with CRPS treated with IV mag reported an improvement in their quality of life and pain up to 6 weeks out. So that was a lot. I know that was kind of sporadic. I didn't feel like putting people to sleep like in the biochemistry classes we all took in med school. So, but I truly do think that nutrition can affect our pain, our mood, and our quality of life. We went over kind of the basics of an anti-inflammatory diet. In general, these are safe to use, but some certain diets, specifically the keto diet, requires some precaution. Sports nutrition is highly individualized. It's hard to give recommendations, kind of generalized. But overall, I think that this is an important topic because not a lot of people, at least as a physician, not a lot of people seem to be talking about it. And I think that there is a role. I think that, diet studies are limited in general, but I've been thinking about this a lot. And I think that we have this perfect environment and almost like a closed environment that we could research some of these ideas in our inpatient rehab units. I feel like people would really respond well to this because it seems like a lot after people go through some of these traumas or devastating events, what I've seen is that they're really willing to change a lot of their lives. And I think that, these aren't easy or the most fun things, but I think people would be interested. And I would be interested to see what the results would be. I think I've also had this idea in my mind that if we could somehow down the road, I know this is so far down the road, but if we could somehow prove that these were effective strategies and at least an adjunct to our care, that we could get people to buy into this, and even insurance could maybe even pay for some of these prescriptions, like almost like a home delivery, like Home Chef or Blue Apron or one of those. Because I think one of the hardest things about adhering to these diets is cost and preparing, and it's hard because not a lot of people know about it. So I think that would be interesting as well. I have my resources in a giant Excel spreadsheet. I'm happy to send it out either as individual papers or as an entire file But thank you for listening. I hope everyone didn't get too bored, and I'll open the floor to suggestions, concerns, comments, restaurant recommendations, and we'll go from there.
Hey, great talk, Will. I was really interesting, kind of similar to what you were, like some of these ideas that you were talking about. When I was a med student, I did a rotation at Kaiser in nutrition, and they had a similar a kind of program that was set up for their cancer patients where they would kind of talk about nutrition. And like you were saying, it just seems to give this sense of power to patients that, you know, despite all these things that we're doing to them as doctors and prescriptions we're giving, that was something that they could kind of take control of themselves. So I think that would be awesome to do something like that on our rehab unit. You know, even could be like a group thing that patients go through together. So I love that, and great job.
Absolutely. Thanks.
I think Michael Bade has a question.
Hey, well, great talk. I'm over on the PT side of the house. I was actually recently down at UC Health Stedman, and they're developing like really, you know, an interesting clinical model where they want to have like older adults come through an assessment, like a senior athletic assessment of some type. And they have strong interest in a nutrition component actually across the lifespan. And you know what people can do nutritionally to enhance rehabilitation. And one of the main questions and one of the main barriers actually is finding resources for can we get a dietitian down there? I'm curious, what do you think in terms of resources for patients we have in the UCH system? Like, so if I want to change my diet to, you know, maybe reduce my knee osteoarthritis or recover better from an injury, surgery, who do I go talk to about doing that? Because I often find it's great to give, I love these kinds of talks to think about, you know, what are some of the key movers of recovery that we could potentially modify through diet, but how do we help individuals or patients? And so I'm curious about your thoughts on who we can collaborate as rehabilitation professionals and resources within the UCH system.
Sure. So even today on the rehab unit, we have this young kid who unfortunately has a new spinal cord injury, and he just wanted to learn more about the nutritional requirements as his body is changing, and obviously there are different things that he needs to be thinking about now that he has more of this like neurogenic bowel, as well as, you know, he's not going to be as active. He's a really active gentleman. And he just wanted to learn more about it. And so I just reached out to nutrition today and was like, hey, can you just come talk to him about this a little bit? But in my head, I'm thinking, I've thought a lot about, I don't know if anybody, if any of the dietitians that I've talked to a couple at the VA when I was there earlier this year, as well as at U, and it just doesn't seem to be well thought about from their perspective. So in my mind, I would love to see, like you were hinting at, is that a dietitian involved in maybe even some of these multidisciplinary pain clinics as well, to just do an assessment. I don't think it would be that hard. Also, I think on this topic, maybe unrelated a little bit, is that I think apps, like weight loss apps, I read a couple of studies about how effective they are. If we could somehow provide maybe an educational or app where you can put in the food that you're eating, that's been shown to be a pretty effective way of weight loss. So I think that would be also a way to go about it.
So Will, there weren't any studies looking at those apps like MyFitnessPal on other options? Like I know they can record your like macronutrients, and it didn't talk anything like about that.
No, I didn't see anything. Don't go try to steal my idea here, all right?
Yeah, I mean, the stuff is out there and you can use it. Dr. St. Fard likes to recommend that to patients, especially kind of on the flip side, not for weight loss, but for weight gain. Patients that are not taking in enough calories, like ultra runners and stuff.
Yeah, absolutely. And Mark, to get back to your question last month about like alcohol or like other things damaging. So alcohol can increase oxidative stress. I didn't necessarily read anything any studies, but it's been linked to oxidative stress as a mechanism of potential malignancy, like in liver disease. But that sports article I talked about specifically mentioned alcohol as it's okay in moderation. So there's been no like general guidelines really.
Thanks.
Sure thing.
Hey, well, I just wanted to get your opinion on kind of like clinically moving forward after reading all this. Do you think this will change your practice at all? Like, are there any supplements that you think you'll actually start recommending to patients for certain disorders? I was particularly interested in like if we have recreational athletes and more kind of brought like ultra athletes, that data on the creatine was really interesting.
Yeah. So something I forgot to mention about creatine is that study looking at injury prevention actually looked at also like markers of like any damage to your liver or renal or like ability to synthesize creatine when you stop supplementing. So all of these things were not found in these treatment groups. So I think relatively, and actually that paper was kind of a joint statement from those groups, and they basically said inhibiting people from taking creatine supplementation could be detrimental. And so they kind of encouraged it. So I wouldn't be shy about that. I also think magnesium, I mean, it's incredibly safe. We give it to pregnant people for the treatment of like pre-E and things like that. So I think that's a relatively safe one to try. And really no side effects, or maybe some mild nausea and vomiting were reported, but outside of that, it was well tolerated and safe. But I think, yeah, I would love to incorporate this somehow into my practice one day. I think it'd be sweet.
Awesome, thanks.
You're welcome.
You're getting lots of shout outs in the chat for a great job. Dr. Torbenson, Kristen, Christina, Malia, Dr. Sanchez, Eddie, Dr. Friedrich, Michael Bade, and Dr. Laker.
Cool, thanks.
Now you get to go enjoy your cheeseburger after all.
Yeah, I made myself really hungry with all those pictures for sure.